तो herpes Same. If you wanted to like do herpes like the swab.
Okay. Good morning, everyone. So I will be discussing Journal Club article today regarding GI because I think it's a very fascinating topic, and we see so many Dr. Zhu's patients who come in with IBD, and some of the tests we do run on patients include all of these inflammatory markers. I remember last block we had an 18, 19-year-old male who came in with like abscess, and we diagnosed with him with Crohn's. It was the first time we diagnosed somebody on floor. So it was really interesting, and I thought it would delve a little bit more into like lab work and what the best modality is to identify these patients with these disorders. So this is a test strategies to predict inflammatory bowel disease among children with non-bloody diarrhea. And this article was published in our pediatrics volume for this month, August 2020. So what's known on this subject so far? Basically, we do know IBD exists, and there's a lot of different causes of chronic non-bloody diarrhea. And instead of yielding to using an endoscopy every time, are there better ways to identify this and separate this? So we have less people who are unnecessarily scoped for IBD. So this study adds a couple of things. So it makes you realize that having your clinical findings, which is your good history and physical, having good CRP result, hemoglobin, calprotectin, these are very highly accurate and non-invasive ways to start your investigation of possible IBD. So the objectives of the study was 4 diagnostic strategies that they used to see children who have these chronic non-bloody diarrhea and abdominal pain, and how many of them do actually test positive. So this cohort study was mainly done in like Netherlands, Belgium, and Switzerland, and they used about 193 patients that were totally weeded out. They were aged 6 to 18 years old, and the symptoms were assessed, and I'm going to go into details of exactly which ones, and a CRP level of greater than 10 was used, hemoglobin that was less than 2 standard deviation for the age and sex to see if they have anemia or not, and a fecal calprotectin level, which I know we use commonly when you're working with one of Dr. Zhu's patients, and the cutoff that they used was 250 for the study. So the exclusion criteria for patients in the study was anyone who had any kind of rectal bleeding or perianal disease, they were excluded from this, because no matter what, those patients will undergo endoscopy anyway. So initially from the study results, just a brief overview, about 11% of the children did have IBD. And once you start adding more things besides your history and physical, including your CRP, hemoglobin, calprotectin levels, those numbers, which what they call AUC is like your area underneath the curve. So when you have a graph, a perfect AUC is the number 1. That means you have 0 false positives and 0 false negatives. That's like the best place to be. So as you can see, more criteria they added, the AUC started getting closer to 1. So combining symptoms, blood and stool markers, and that was close to 0.997. So basically, just as the conclusion of the study was, this is the optimal test strategy that allows pediatricians to reserve diagnostic endoscopy for children at only at high risk of IBD, and not all children who show symptoms of abdominal pain or chronic non-bloody diarrhea. So some of the symptoms they used, so symptoms include persistent non-bloody diarrhea, which is done in the history taking. And the criteria is duration of more than 4 weeks, or you have recurrent non-bloody diarrhea and abdominal pain, which is more than 2 episodes in 6 months, or any kind of unintended weight loss. They also looked at your family history, if you had a first-degree relative with IBD or any kind of extraintestinal symptoms. And this include episcleritis, uveitis, your erythema nodosum, psoriasis, finger clubbing, and arthritis. The blood markers they mainly used was CRP and a level greater than 10. And anemia, the way they assessed by the 2 standard deviation was if they're age 4 to 12, less than 7.1 was the cutoff, boys 12 to 18 less than 8.1, and girls 12 to 18 less than 7.4 to account for menstruation. So, and the stool markers they used was the fecal calprotectin, and it was greater than 250. So one of the older studies that used to be done for markers, they used to have the cutoff for fecal calprotectin at 50. This was great because you saw a lot of patients including the criteria, but a lot of those patients also went unnecessary or too many accounts of endoscopies. So they raised the bar to 250. So like I mentioned before, persistent rectal bleeding, perianal disease, no matter what, you have to do an endoscopy anyway. But now we're trying to triage these tests to distinguish who is an immediate referral need for endoscopy. So before, like I mentioned, they used to do a single fecal calprotectin level only. And when you had a cutoff of 50, they had high sensitivity, about 99%, but the specificity was not that great. It was only around 65% before. So this was one of the reasons that a lot of children wrongly got exposed to endoscopy. And there's a lot of complications with that, including colonic perforation, tear, and a lot of side effects from the anesthesia itself. So they can increase your morbidity for it. So this diagnostic strategy that we're including is a combination of these tests to reduce the number of children who's exposed to this procedure. So the 4 diagnostic strategies that the study used was 1, symptoms alone, 2, symptoms plus any blood markers, 3, symptoms plus fecal calprotectin, and of course, lastly, symptoms plus blood markers plus fecal calprotectin. And I think like on some level, we already know that number 4 sounds like the best option and will probably give you the best results anyway, but we shall go forward. So the study design was history and physical. So the patients were assessed by a local clinician and they included into a secure study website. They also did the blood test at their local hospital. Stool samples was sent and immediately after arrival, they did the fecal calprotectin because the longer these samples stay out, the levels get degraded and are not accurate. And also, the fecal calprotectin concentration greater than 250, they said that these patients need to be undergoing endoscopic biopsy anyway. So if you had a level that was closer to 250 but not quite, they get reevaluated 1 month and then 6 months after just to make sure you're not missing any latent IBD. So age 6 to 18 was the criteria for these participants. They had to have persistent or recurrent, but non-bloody diarrhea and abdominal pain. The patients were included from 16 general hospitals and 3 tertiary care hospitals in Netherlands and Belgium. And they were assessed by general pediatricians and pediatric gastroenterologists. And 6 of these sites had the pediatric endoscopy unit. And like I mentioned before, there's only had very minimal exclusion criteria, and that is if you had any kind of bleeding or any kind of perineal disease, such as abscesses, you are not part of the study. So other data that was collected baseline was, weight loss, first-degree relatives, and extraintestinal symptoms. And the way they analyzed the result was to see what the area underneath the receiving operative character. So that's the AUC, the area underneath the curve. So like I mentioned before, ideal is to fill in the curve and get close to number 1 as much as possible, and to see what is the benefit versus the risk for each of these studies. So just as a side note, there is, the study was conducted according to the Principles Declaration of Helsinki is pretty much to say that each of the patients in the studies was monitored and followed just to make sure it was completely ethical, and it was done in a blinded way where the results were collected and no one was identified to the study as well. So for the cohort, they started off with a total of 354 patients. So out of those patients, there were 135 that had persistent rectal bleeding or perianal disease, so they were excluded from the study. And there were 15 who had like the stool calprotectin that was severely delayed, so they couldn't use them in the study. So they technically did the study with 204 patients. And the first thing they did was they check with the fecal calprotectin level. If it was greater than 250, that's automatic criteria for them to undergo endoscopy because they're already high risk. And out of the 31 patients who tested positive for greater than 250, 22 So out of the 31, 22 were positive for IBD, and 9 of them were negative for IBD. And from the other patients, there were 11 that were lost to follow-up in the middle. But the 163 patients who had low likelihood of IBD, they did other follow-up alternative, like I said, follow-up in 1 month or follow-up in 6 months, and only 23 of them underwent endoscopy. So you can see the ones who had the low likelihood of IBD, only actually 0. So nobody was positive for it, right? And 162 for them were negative for IBD. So this fecal calprotectin level of greater than 250 is like a huge criteria. If you have any concern that may be less than that, you kind of have to gather more information to confirm your diagnosis. So this study was done from 2014 to 2016, and 135, like I had mentioned, had over blood loss or perineal disease, so they were excluded. 15 were also excluded, and out of the total 204 patients, the 193 was made in the final diagnosis tree. So from the 22 of the 193 that I mentioned right here that were positive for the IBD, that's like 11% of the patients. 8 had ulcerative colitis and 14 had Crohn's disease. So other baseline characteristics for these patients, right? So you have your demographics, you have your symptoms, you have your blood markers, and you have your stool markers. As you can see, the percentage of how appropriate and specific they are increases. And as you know from biostats, when you have a p-value that is less than 0.05, the smaller it is, the more accurate and valid test is, right? So for these markers, the stool markers where your fecal calprotectin is greater than 250, the p-value is less than 0.001, and same for CRP and anemia. There are some other factors that can be disregarded, such as like family history, because it can be very vague and generalized. So this is what they mean by the ROC, the area underneath the curve. So the higher sensitivity you have and the greater specificity you have, that is the ideal case. So what you see in purple here are patients who had the symptoms plus the positive blood markers plus the calprotectin. Their area underneath the curve was close to 0.997. And I had mentioned before that 1 is the place to be, so it is as close as it can get. The other different tests that they had done was the symptoms plus calprotectin itself, which was still very accurate compared to just symptoms plus blood marker only. And the symptoms only, it almost feels like it didn't do nearly anything the other 2 did. So the 4 diagnostic criteria, so symptoms alone was 0.718, symptoms plus blood markers subsequently kept on increasing from 0.93 to 0.967. And lastly, the blood markers plus fecal calprotectin was 0.997. As I mentioned before, this close to 1 is the best place to be because you have 0 false positives and 0 false negatives in your case. So the sensitivity though, so for these 3 strategies, right? So strategy 2, 3, and 4, the sensitivity was 100%, which is great. But the specificity, as you'll notice, starts increasing from 68.4, where it's just the blood test, to 90.1, where it's just the fecal calprotectin, to 96.5. So this is a great specificity to have, along with the criteria where you include everyone and you're not missing any of your patients. So like I had mentioned, 11% were the one who actually tested positive. So the probability, if the strategy 4 were negative, that means that it was reduced to 0%, which is pretty much saying that you are not missing any patients who can be a false negative. So the decision curve analysis strategy 4 had the greatest net benefit for predicting IBD. So strategy 3 was also good. It was better than strategy 2, but and the basic model was pretty much like saying that whether you performed an endoscopy or not, it was just almost like you had the same result. Other accuracy measures, right? So same exact thing. So symptoms only, the sensitivity for that was only 72%. Specificity was still very low, but symptoms plus blood markers significantly increased. The specificity to 68, and when you add the calprotectin, it went up to 90.1%. and then the specificity went up to 96.5%. So discussion. So this was an international prospective multi-center cohort study. So they use your CRP, your symptoms, hemoglobin, fecal calprotectin, as this offers physicians an opportunity to reliably screen children and teenagers with abdominal pain and non-bloody diarrhea before referring them to endoscopy. So this allows physicians to indicate with high reliability which patients are at negligible risk for IBD and therefore should not undergo endoscopy. And it also allows pediatricians to efficiently allocate resources in the endoscopy units by reassuring those with low risk that there's some more time to prioritize those with higher risk for IBD. So this time they mentioned that saved from refraining from unnecessary endoscopies, and they can use it elsewhere in the healthcare system. And it's funny because they are very highly keen on something called gut-directed hypnotherapy in treating patients with functional abdominal pain. So I looked into this a little bit more, and it's very interesting. It's almost like a meditative procedure, like a process where you sit, and it's all about visualization, calming sounds, calming music, and you are really focusing your attention on your gut and speaking to your stomach. And just to make sure, it's like a different way of treating your symptoms, I can say. But they're very much more on the holistic side of medicine. So this was one way of saying that instead of doing unnecessary allopathic care, maybe you need to think of more other ways of treating. So comparison with other studies. So the good thing about this study was there's a large group of like undiagnosed children and teenagers and who had the recurrent non-bloody diarrhea and abdominal pain. And I feel like even in our patient population here, this is something that we see. Like this is something that can be more or less universally applied because you do see patients in our clinic coming in with persistent recurrent non-bloody diarrhea and abdominal pain. And the previous studies that they had, a lot of these studies included patients who did have perianal symptoms or rectal bleeding. So this study took like extra effort just to make sure those patients were excluded. And inclusion of these patients causes overestimation of the discriminating power relative to the practical situation. So basically what they're saying is when you see a patient who does have perianal symptoms over rectal bleeding, you tend to reach for a diagnostic strategy such as endoscopy, right? And sometimes you end up relying on them over excessively because you rely on it to make your final diagnosis and you don't really need to, is what they're trying to say. So there are also limitations to the study. Although you have like a great sensitivity to 100%, but you can still have, you don't have 100% specificity, so you will still see patients who are occasionally missed. But that's why it's very important to have a good follow-up with physical lab examinations and make sure you repeat the levels again within 1 to 6 months, just to make sure it's not a latent type of IBD. And also the ones who are low risk, those are ones that you shouldn't disregard, and you make sure you follow up with them once this is done. So how will this impact an actual clinical practice, right? So this is great because, you know, there's certain blood work that you can do in a clinical setting, but you have to see if it's something that can be universally applied because it depends on health professionals' resource use, what they have access to, and time constraint as well. So there are some limitations where it can be extended to other parts of the world. So, and another limitation they had mentioned was also the calprotectin that is used. So they only used one type, which is an enzyme-linked immunoabsorbent assay from one manufacturer only. And their cutoff level was 250. But at the same time, there are some assays, this 250 number is a little bit more variable. So we do need to look into a standardized assay that can be used everywhere. They also mentioned that ESR is not the best lab marker to use because sometimes you can have inverse correlation numbers with the hemoglobin and then can kind of like alter your interpretation of the results. And they also mentioned albumin, which can be abnormal in a lot of different pathologies and in pediatric patients, but this was something that they had addressed in this study as well. And for this one, as you can see, the one that is in purple is when symptoms, blood markers, and calprotectin are positive. So you have a net benefit compared to the risk that you're taking when you're doing the blood work. Compared to the others, it feels like the benefit is much more increased when you do all three of these at the same time, compared to just piecing it out little by little. So what are the implications for practice? So pediatricians can be reassured that properly evaluating children using clinical findings, CRP, hemoglobin, calprotectin is highly accurate, and it's a non-invasive approach to investigation of possible IBD in any clinical setting. And conclusion, so evaluating symptoms plus blood and stool markers in patients with non-bloody diarrhea is the optimal test strategy that allows you to reserve a diagnostic endoscopy for children who are at high risk and really do need this procedure. And that's it. That was the study.
Aish, I have a question.
Sure.
Where did they do the blood markers in the study?
So
which part? So after, I know that after they choose the number of patients,
yeah.
You mentioned earlier that in all of them they were doing the fecal calprotectin kind of first.
So
Yeah.
what they did was this, right? So they did 4 different sets of patients. They didn't really go into the actual amount of how many patients per like different.
Each arm?
Yes.
Okay.
So they did one set was just symptoms only. Then they did symptoms plus blood markers, symptoms plus fecal calprotectin, and then one leg with all of these numbers. That's what I got out of the study.
Okay.
Yeah.
So
like,
they separate the 204 patients in the 4.
The 193, because I think the 204 were included, and then like 11 were lost to follow up.
Okay, kind of like in the analysis, I think so, right? Okay.
Were they randomly distributed to the treatment groups?
Yes, that's what they mentioned. They said it was randomly distributed. The only exclusion criteria, like I mentioned, was having no occult blood loss, and there was no other signs of like abscesses or perianal disease. Otherwise, all of them were randomly distributed between age 6 and 18. They also mentioned the ones that were 12 and above, they got, like the consent was taken from the parents, but the ones who were 12 and above, they also got assent from the patients themselves as well. But the distribution was random.
Did they include any tables with demographics to see if there's any difference between these 4 groups, like with age and risk factors? You just want to see that before you test these 4 groups that they're homogeneous, right? That your value is greater than 0.05.
Right, definitely. They didn't include anything for the demographics. I do think that is a shortcoming for the study itself, because if we were to take this study and apply it here, like for even in Staten Island, you'll see a huge variation in demographics. I think the study was mainly done in the 3 countries like Belgium, Netherlands, and Switzerland. So I think it was very much not as distributed.
So, right, so we don't know if those who tested positive or who were in one group, if they had any other risk factors or any other conditions, and that could have been a bias to that.
Right.
That diagnostic test group.
I think that was a very good point, Melissa. Actually, without the eliminating a lot of confounders such as ethnicity, because in Europe they are very homogeneous, but in the United States, you know that the Crohn's disease is more prevalent in the Hasidic Jews. So the clinical manifestation is slightly different between African American and Caucasian group in Crohn's disease. But in Europe, I think they should have mentioned that in discussion, but although they are pretty homogeneous, this is from Netherlands, right?
Right.
That's one thing. Another thing is, I hope everybody understands the reason they didn't include those patients who has an obvious occult blood or grossly the bloody stool and perianal disease group, because fecal calprotectin has been valid. It's a very good marker, by the way, for neutrophil. So this protein is predominantly from neutrophil. So if let's say a patient who has a perianal fissure from constipation, if you have a bleeding or cord blood positive, fecal calprotectin sometimes get to the thousands. So that's why this marker is great for following up remission and has already had the established diagnosis. But to use it to make a good still not that reliable because specificity is very low. So yeah, neutrophil is a source of the fecal calprotectin. It's a 50% neutrophil cytosol protein is calprotectin. So I use this to just eliminate the organic GI problem. For example, people from IBS or constipation. So even for the sake of H. pylori, I sometimes just add this to the stool study, make sure I'm not missing the early stage of IBD.
Thank you, Dr. Zhu.
Any more questions, guys?
So is this the current standard of care, blood test and calprotectin?
It's calprotectin is not current care for diagnostic purpose.
So yes, standard.
Always use it, just like when you use CRP or saturate for any inflammatory conditions. So yes, just use calprotectin as a sole marker is not recommended. You got to use this as a supporting evidence. But you have to follow this because everybody has different levels. Some people without having any symptoms, calprotectin can easily go up over 250 microgram per gram of stool. So yeah, you got to use it in a clinical context. You got to use it to be careful. But I normally use it as a monitoring marker for a patient who has been, let's say, on Remicade, who is in perfect full remission. I sometimes use it together with the CBC CRP, just make sure if patient has any flares or loss of a response to Remicade. So it's not standard yet. Calprotectin is pretty much new. It's available for 10 years now. And we don't still have any cutoff value for what is considered as a normal. A lot of people use a 250, but it still varies. So it's good marker, but still has not been established as a what can I say, standard.
Dr. Zhu, in this study, they said that they don't really use the ESR because it can be confounding.
Yeah,
they don't use albumin either. Do you use that in your study?
You're right. I don't use ESR also because ESR's most technique in the laboratory, the ESR is affected to the RBC numbers. Let's say a patient has anemia. Sometimes ESR can cause different numbers. So we don't rely on ESR. Some people put the ESR CRP together, but CRP is now pretty reliable now. You don't have to do ESR. Right? So yes, I normally more rely on CRP than ESR because ESR can be unpredictable, especially if a patient develops anemia, the anemia of a chronic disease, and sometimes can disguise and can give a falsely elevated, sometimes even falsely the lower level. It's very difficult. No.
How long did they follow up these patients for?
So these patients were only followed up to 6 months. So the ones who, like you had the initial study where it was done and they said who tested positive for symptoms of like IBD, who needed endoscopies done. The ones who are the lower risk for IBD, fecal calprotectin less than 250, they only followed up for another 6 months. But most of it was like their recommendation because I don't think it was a full follow-up, but just to continue care with their own pediatrician.
Yeah, so the practice between Europe and United States, we have different society. One is Eastern Society, European Society, and NOSPGAN is American Society, Peds GI. So we, in the United States, we tend to scope these kids, right? And just to make sure, exclude the disease or rule out, rule in. But in Europe, though, they try not to do endoscopy or colonoscopy unless it's absolutely necessary. That's why they are doing a lot of research, try to find out if they can reduce the number of the procedure. It's completely opposite from United States. We try to do as many as we could. So yeah, that's kind of I don't know, a lot of GI specialists, if you have abdominal pain, they just do scope. I want to rule out IBS or IBD, but in Europe, they are slightly different. They tend to try not to do endoscopy or colonoscopy.
Dr. Su, they had mentioned something called the gut-directed hypnotherapy because they said the more resources can be put towards that if you do less endoscopies. Have you ever referred any of your patients to that?
No, I've never done this because we don't have any centralized center who can do this. It's some of motility experts, they try to incorporate this into practice, but I can't find it anywhere I can send in the East Coast. No.
Do you think you can use these guidelines to help determine who gets an endoscopy versus not, Aish? I mean, so the insurance companies, right, pretty much decide if you are approved an endoscopy versus not. So if you're director of an insurance company, would you recommend that these guidelines be used?
Melissa, that was an excellent point. Actually, a lot of time, it depends on the patient's condition. Some insurance deny procedure, all right? If you want to scope everybody, even in a kid who perfectly just looks like IBS, some insurance company deny the procedure. Yes, in those cases, and you have to show some evidence showing that this patient needs confirmation. He needs to do endoscopy. Yes, sometimes you need to show the data. Listen, every data point out this case probably has IBD and require colonoscopy confirmation. So in that case, absolutely, you need more data like this. From the other end also, sometimes if you want to do the colonoscopy to make a diagnosis, but if patient is very sick, all right, and patient pretty sick and severe anemia, severely malnourished, and anesthesia sometimes don't feel comfortable, then those cases you need a therapy, but without colonoscopy and without pathological diagnosis, it's very difficult to initiate the therapy. In those cases, sometimes we do imaging and these clinical study and just go ahead making clinical diagnosis and start therapy. Yes, I think that's an excellent point.
All right, so you need to know that's why we do these exercises, right? We tease apart the studies that policies and guidelines are that are referenced by policies and guidelines, right? So if you go into a discussion with an insurance director who quotes this study, current day and time, you can say that, well, they didn't really demonstrate a difference between the four groups. And this was really targeted for a European population, which was more homogeneous, and we don't even know if there was a difference in age or race or health of these patients. So I don't think that paper applies to our current setting. Yes, there are many advantages of this paper. It will probably save us so much with regards to anesthesia and procedures and even time, right? And anxiety with regards to the parents for, you know, their child going through anesthesia and getting a procedure, and the goals are great. But I agree with the conclusion or in the discussion of this study, you do need a bigger clinical trial, and you need to have a larger N. You need to be able to prove that these four groups are homogeneous pre-testing. Okay, and if it turns out that method C is equal, not even, you know, not even superior to testing D, then why not use test D, right? If you're going to save X amount of dollars. So anyway, but great talk, Aish, great presentation.
Thank you.
Thank you, Aish.
Thank you.
Thank you, Aish. Excellent job.
Thank you, Dr. Zhu.
Thank you.